Let's continue with the 7th plenary session of ISOT 2021 on transplantation in HIV-positive patients, current practice and management strategies. May I invite the speaker, Dr. Elmi Muller. I now invite the chairpersons for the plenary session, Dr. Ravi Raju, Dr. Samir Chobe, and Dr. Shruti Dev. May I now take this opportunity to request Professor Vivek Ute to introduce a speaker to us.
It is my pleasure to introduce Professor Elmi Muller, President-elect, the Transplantation Society, Head of Transplant Services at Groote Hospital, Cape Town, South Africa. Madam is recently appointed as new Dean of Faculty of Medicine and Health Sciences at Stellenbosch University. Professor Elmi Muller is pioneering clinician who performed the first HIV positive to positive transplant in the world literature. She was featured in Lancet in 2012 under the title Elmi Muller, Bending Rules, Changing Guidelines and Making History. ISOT is pleased to have the living legend in transplant world, Professor Elmi Muller, to speak on transplant in HIV. Over to Professor Elmi Muller.
Thank you so much for that kind introduction, and thank you for the invitation to be here today. I'm going to go ahead and share my screen. So I'm going to talk today about HIV positive to positive transplantation in South Africa. I'm going to focus on drug resistance, opportunistic infections, and tell you a little bit of the outcomes which has given many HIV positive people a new lease on life. Now, we in South Africa and you guys in India, we are seeing extremely high HIV rates compared to the rest of the world. So it's appropriate that we should discuss this and lead clinical investigations and clinical initiatives to drive treatment options for HIV positive patients. South Africa has got a very high prevalence of HIV. We don't have an official registry, but we know from our antenatal clinic data that almost 21% of our females who present are HIV positive. And the majority of these patients are Black African patients, although HIV is prevalent in all race groups. But a very important note here is that 84% of our population have no medical insurance. So they depend on the South African healthcare or the government healthcare. And for that reason, dialysis is an extremely scarce commodity. It's expensive, and we weekly sit down and decide which patients will become dialysis patients. And for us, we would categorize the patients in category 1, 2, or 3. Category 1 would be the perfect patient who probably have nothing else wrong with them but except for renal failure, which is extremely rare. Category 2 patients will have some medical condition which will still make them suitable for dialysis as soon as we have a space. And category 3 patients would be refused dialysis. Now, when I started the HIV positive to positive program, HIV was classified as category 3, and that is for that reason that I decided to use HIV positive donors. And you can see here, this slide has got data till 2017, but I've updated the others, and we are now at 55 transplants for HIV positive patients. We screen all our donor tests with a combination of antibody assays and NAT. So most of our donors had both tests. And you can see here that most of these tests have got a small false negative rate. And one of the advantages starting an HIV positive to positive program is that you can also use these donors, which in other circumstances might have not been used. Now, what do the donors in South Africa look like? And this is quite unique, and I don't know, we can explore whether it's similar in India, but for us, the majority of our donors are trauma donors. So we have many people who die because of either assault or gunshots or motor vehicle accidents, and less patients who die for medical conditions concerned with HIV. Remember, many patients who've got opportunistic infections or severe medical disease combined with HIV would not be suitable donors. So in a way, the reason why they are not on this slide is not because they don't exist, but more because they don't seem to be such good donors. You can see there that the majority of our donors are A blood group. This is the case for HIV transplantation as well as for our general transplant pool. Now, for today's talk, I'm going to talk about what I see as the important things to look at if you want to use an HIV donor. And I think there are three broad groups of donor considerations. The one is the quality of the kidney. The second one is the general risk that this donor has for an opportunistic infection, which can become a donor-derived infection in the recipient. So you want to look at that. And the third thing is that you don't want to expose your recipient to antiretroviral therapy resistance. So for us, we are not concentrating on that so much at the moment. I'm going to show you why. But as our donors get more exposed to antiretroviral therapy, that's another consideration. So is there resistance to antiretroviral therapy? And are you actually going to make your recipient in some other way resistant to the drugs if you transplant them with this kidney? Now, let's look at quality of kidney. Here, I think the most important consideration is the recurrence of HIV nephropathy in the kidney. And we have seen many different reports in the literature around this issue, some reporting it more, some reporting it less. But what it basically is it's an aggressive form of FSGS, which is related to the virus. And it affects the kidney, and many of the patients who are getting renal failure because and have HIV has it because of HIV-associated nephropathy. Now, how do we test the donor for this condition? In South Africa, we concentrate on proteinuria. So we do a urine and protein dipstick, and then if it is high, we would do a urine PCR and we would screen the patient for proteinuria. And I think that is quite a good way of deciding whether this kidney is okay to use or not. But I'm going to show you some interesting results from some of the kidneys that I've used. We do also look at the clinical history. I try and find out as much as I can about the donor. Has the donor been on ART? What is the serum creatinine? So those things would influence me. And we do a protocol biopsy on all our donor kidneys, but we don't wait for that result to make a decision around transplantation. So it's a thing we do for our academic interest and for monitoring the patient long term, but it is not a screening tool. Now, the second risk factor is that you're going to give the recipient a kidney, but you're going to transplant another infection and you're going to give the recipient a very bad donor-derived infection. And for us in South Africa, that issue is really, firstly, tuberculosis. We have got a lot of tuberculosis in our country, and we know that if you have tuberculosis plus HIV, that is quite a poor prognosis. Now, I've put this slide on just to give you an idea of our numbers. This is data which is a little bit old, but it's still very similar. Of the patients in South Africa that has got tuberculosis, on the right-hand side in the block, you can see we've got quite a big percentage of multi-drug resistant tuberculosis and extensive drug resistant tuberculosis. And then if you look at those patients, there's a large proportion of them that also have HIV. And if they have a combination of these multi-drug and extensive drug tuberculosis plus HIV, there is a very bad prognosis of about 27.8% mortality rate. So that is a big deal. And for that reason, if I have a donor that has got tuberculosis where I'm unsure about the treatment or where I'm concerned about resistance, I don't use that donor. Now, antiretroviral therapy resistance is the third thing I mentioned. Now, in South Africa, we have got very low antiretroviral therapy resistance rates. It's probably less than 5%. This study is one of the studies that was done among the first HIV positive people in South Africa to benefit from antiretroviral drugs. And this observational study suggests that after 4 or 8 years of access to antiretroviral therapy in these areas, drug resistance mutations in the naive population were still very low. So I am at the moment in South Africa not too worried about using a donor that has been exposed to antiretroviral therapy, because I know my chances of transplanting a drug-resistant kidney is extremely small. But we also know from the curve that when you start in any population giving treatment, antiretroviral therapy, there would be some naturally occurring viral variants, but most of the virus would be drug susceptible. And then as time goes on, you would start seeing more drug-resistant virus. And this is usually because patients are not always compliant, and resistance drugs would spread between different patient groups. And after a while in time, most populations do see an increase in drug-resistant virus. So in South Africa, we are not quite there yet. I know in the States there is a lot more drug resistance, but on the other hand, there are also new antiretroviral therapy available that is changing this landscape. Showing you some of the results of our 55 transplant recipients as of today, you will see that the majority of them are Black African patients. 39% of them are female, and they are an average age of 41, which is very young and which reflects more or less our South African HIV population. We don't match HLA in our transplant program, so they are mostly mismatched. And the only requirements for them to get onto the transplant is that they have to be virally suppressed, and they have to be on a stable antiretroviral therapy treatment regimen. Of course, they can't have severe opportunistic infections or severe other systemic diseases, but those are the HIV requirements. And in this patient group, everybody had an undetectable viral load at the time when we gave them a transplant. Now, it's just interesting to note that a lot of our recipients also have HIV-associated nephropathy as a cause of their HIV disease. You can see here around about 66% had HIV-associated nephropathy. Remember, our HIV treatment came in quite late, and we're still seeing a lot of people who weren't on treatment. Now, if you look at the patients who received transplants, or the transplant population, you will see that I have got a small group with B, but not very many. And then I have got a protease inhibitor and NNRTI based, sort of 40% on protease inhibitors and 57% on NNRTIs. And we're just basically at the moment looking at the outcomes of those two groups to compare what the impact was. And I can say to you that the protease inhibitors are more difficult to manage, and they get probably more rejection rates. But important to note in the right-hand table is that everybody in my study gets thymoglobulin induction therapy. And that is because the rejection rates in this patient group is so extremely high. Here you can see some of our patient and graft survival statistics. At 5 years, our patient survival is 82.1% and our graft survival 77.5%. But we are seeing extremely high rejection rates. And this is not only us. The same is observed in many other places who are doing HIV positive to positive or HIV negative to positive transplantation. So in the first 2 years, we are seeing still a rejection rate of almost 38.8%. And that means you know, that despite very aggressive anti-rejection therapy with ATG, we still find that after the year, when the ATG starts wearing off, we often see another rejection episode. Now, 2 patients in my study experienced graft failure due to acute rejection in the first year after the transplant, and 3 patients lost their graft because of chronic rejection between 2 and 6 years post-transplant. So rejection is still a major important thing to consider when we think about HIV-positive transplantation. Now, virological questions are very important when you start thinking about using an HIV-positive donor, because as I explained in my previous slides, we don't want to give the recipient issues with their new HIV virus. So we have done some ultra-deep sequencing of the HIV virus, looking for viral resistant patterns and haplotyping the virus in all our recipients and trying to find if there were issues with using a second virus in this HIV positive transplant program. So we've stored plasma from both our donor and recipients in each of these transplants. We stored urine, we've got biopsy, and we've sequenced these viruses both in the donors and the recipients to see what happens. And we found that there were only, actually I should just quickly say this. We also looked at the amount of antiretroviral therapy in all our donors using mass spectrometry. And this is because most of our donors report that they've not been on antiretroviral therapy. And of course, that is important when you start looking for viral resistance patterns. So here you can see all our donors who did say that they weren't on treatment. Most of them were correct. But we did pick up here and there a person where we actually did find some medication on mass spec which weren't reported. And that probably could be related to the fact that we get consent from the families, and the families are not always completely aware of the patient's medical history. Some people don't share their HIV status with their family. It's still very stigmatized in South Africa. So it is possible that the patient is on antiretroviral therapy, but the family, when they say we could use the organs, tell us nothing about the HIV. The other thing that's important here is to see that most of our donors have got quite high viral loads. And this is because many people in South Africa are still not on antiretroviral therapy, and they get detected incidentally when they become a brain dead donor. So using a high viral load donor in our experience has not been a problem. So I've told you that we've sequenced the virus, and this is one of the methods that I'll just describe to you. So we tried to define the amount of virus in the donor and the recipients, and how we did it. We did a normal viral load in the plasma on all the donors and the recipients, and then we also did what we call a proviral load using ddPCR. And basically, if you look at the T cell, you can see in that little DNA strand, I've marked the proviral HIV DNA with red. And basically, HIV will enter a cell and then go and sit in this memory cell and start replicating from there. So this is the type of infection that we expect to see in our donors, and this is why we did sequencing of this virus to see what happens. Now, here you can see just on the right-hand table, I'm just showing you a little bit how it looks, the data looks. We found a proviral range between 13 and 1,304 copies per million in the PBMC. And this is in all our recipients. And the median there is 179 copies per million. And we did the same in all our donors. And then we went and we looked for the RT gene in these donors and in these recipients. And this RT gene is really showing us if there has been any previous drug resistance. So it's a way of screening for drug resistance in the donor and recipient. And we didn't find in our South African population that there were any previous drug resistance. We then went ahead and we did another type of sequencing, which is sequencing for the ENF gene. And the ENF gene is important because that is one of the ways we can look for superinfection between the donor and the recipient. So we can basically see in the recipient if there is any similarity to the donor virus. And that way we can, with reasonable certainty, say whether the donor virus has infiltrated into the recipient's body and had made an impact in terms of bringing a new viral strain into the body, and not only bringing in the viral strain, but also becoming settling into this person and becoming an issue. So as you can expect, we didn't really have much antiretroviral therapy resistance in our donors. We sequenced many people, and there was only one person, which was interesting. We couldn't find any evidence of drug, but we could find that his viral load is very suppressed. So he was labeled an elite controller, and this donor was used in 2012. Unfortunately, the first recipient who got this kidney lost her kidney, and the second recipient died. So we don't really know what would have happened to these two recipients who received this, this donor kidney. Another interesting donor was a donor with an extremely high viral load, 7.8 million copies per mole, which we thought was suggestive of a late stage of infection. We used this donor in 2013, and on the implant biopsy, the kidney was reported as having signs of HIVAN. It had mild increase in mesangium with arterial hyalinization. The first recipient, after a month, we did another biopsy, and all those changes in the kidney were gone. And there were no signs of HIVAN, but this patient did get an acute rejection. But after 5 years, the patient had excellent graft function and no biopsy changes. And the second recipient, who was also on standard immune suppression, also had no issues. So you can see here their results, their creatinines. The one on the left-hand side is 2018 and 2017, creatinine of 96, creatinine of 111, undetectable viral load, good CD4, and they are still doing well. So we haven't had any HIVAN, we haven't had any rejection again, despite using a very high viral load kidney. Now, I've explained to you in the beginning earlier in my talk that we sequenced these viruses to look for similarity between the donor virus and the recipient virus. And this is the type of result you find where you're seeing HIV virus, HIV from the recipient in blue, and you can try and find if there is any outliers in this, which isn't related to the original virus. And in this red one, there are a few outliers which relate to the donor virus. And that is also sometimes projected on this type of tree, where they look at all these different viruses and then find the outliers and decide whether there are any relatedness between the recipient and the donor virus. And in all our 55 patients, we could only find one recipient where the virus was 98% similar to the donor virus. So we know that there had been some form of viral enhancement from the donor in this recipient. And this person had what we would call a dual infection. But in terms of clinical outcome, this patient did very well, had normal graft function and undetectable clinical viral load despite this finding. A last interesting finding from the study data is that we are seeing quite a drop in pro-viral load after the ATG. Now, remember, the virus needs a T cell in order to duplicate. And we are, by giving the recipient ATG, we are basically wiping out these T cells. And then we're giving the recipient a new viral strain, but this virus hasn't got anywhere to go and sit. So we are seeing very, very low pro-viral loads after ATG treatment. So that's just an interesting finding from our study. I'm going to finish the talk by just talking about protocol biopsies. Now, we do a lot of protocol biopsies, and partly why we do it is because we are very concerned. It's a study, and we don't want to give the patient a marginal kidney. But of our 55 patients, there were 6 patients who, through the years, had some features of HIVAN, and they were described, the terminology, I'm not a pathologist, so the terminology always changes, but they were described as fetal glomeruli, microcysts, podocyte changes, basement membrane changes. I didn't want for this talk to really go into that much, but I think it's important to know that there are sometimes HIV-associated nephropathy changes in the long-term follow-up of your patient, and that it is very important to monitor for that. What I can say is they take a long time to develop, and they're not usually clinically significant. The second thing we see on protocol biopsies is sometimes drug toxicity, same as with a non-HIV patient group. So we saw that in 6 of our patients. In 4 of our patients, we saw features of chronic allograft nephropathy, and in 4 patients, we saw chronic vascular rejection changes. We had 2 patients in the HIV-associated nephropathy group that lost their graft at around about 4 years, and we had 2 patients that lost their graft at 1 year, and between 2 and 6 years who had vascular rejection. Now, it's very difficult to report on this histology. Many of these patients have got multiple factors going on in their histology. We might see features of rejection or interstitial fibrosis. We might see features of HIV-associated nephropathy. And sometimes these things would also overlap with things like rejection or drug reactions. I'm just going to quickly run through some of these things just for your interest. We know that HIV-associated nephropathy can be one of these 4 groups: glomerular, tubular, interstitial, vascular, or some other features. And I'm just going to show you some of these cases because I think they're quite interesting. The first patient that I want to show you is a 1-year protocol biopsy who had no HIVAN features at that time. He was reported as having borderline rejection, interstitial inflammation with an increased mesangial matrix and some features of ATN. So no reporting of any HIV-associated nephropathy. At 2 years and 2 months, we did the second protocol biopsy, and at this point in time, the patient had a solidified glomerulus, which was reported as a possible feature of HIV-associated nephropathy. At 3 years, the patient started getting proteinuria, had a collapsing FSGS with plasma cell infiltrates and microcysts, and it looked at this point to us like this kidney was developing HIV-associated nephropathy. And the patient is one of the ones that I've told you earlier, I've lost her graft. So it is important for us, if we think about using HIV-positive transplant kidneys, to think about these 5, what I would call key home messages. Remember that all my data comes from the South African pool, which currently we don't have antiretroviral therapy drug resistance in our donors. So for us, it's not a problem. We are very royal in terms of using donors if they have fairly good histology and clinical results. We don't wait for histology and we're using them, and we don't wait for antiretroviral therapy testing. So that's the first thing. The second thing is, with our sequencing studies, we have shown that superinfection is extremely rare, and in the 55 patients, we haven't really had any clinical issues with superinfection. Thirdly, we haven't seen superinfection of the virus even with temporary suspension of antiretroviral therapy. I've had one patient who lost antiretroviral therapy for about 3 months. She was moving to her home office, in the Eastern Cape, and then came back and didn't have therapy for 3 months. Came back and started therapy again, and we didn't have any problems. So in our experience, it's not been a big problem. Fourth, the proviral load, interestingly, does drop after ATG therapy. So ATG not only prevents rejection, but possibly also helps for the virus. And lastly, HIV-associated nephropathy recurrence is a risk, and that risk needs to be determined and monitored very closely, and we are looking at this also in more detail. So thank you very much for giving me the opportunity to do the talk, and thank you very much to my team in South Africa.
Yeah, thank you very much, Professor Muller. And thank you very much for your lucid and very informative talk today. And I congratulate you for your wonderful pioneering work on HIV patients and transplantation in HIV positive patients. Now I realize how you have become the first woman to be appointed as Dean of Medicine and Health Sciences in the University of Stellenbosch. Not only that, now I also realized why you have become the most influential woman in Africa and also Woman of the Year award. Congratulations to you once more. And I have, before opening the talk for discussion, I have a few questions from myself. The first one is, do you have any different opportunistic infection prophylaxis in these people? That is one. Second one is, you are both a kidney and liver transplant surgeon. So have you done any liver transplants from HIV positive individuals to HIV positive patients? Was there any such thing? A pioneering work, have you done that? And the third question is, it's very well known that HIV positive patients are immunodeficient in several ways. But still we know that acute rejection rates are very high, higher than in HIV negative patients. Why is this paradoxical situation, and how do you manage for getting a good outcome in these people?
Thank you. Those are great questions. So let me address the prophylaxis. We are currently prophylaxing for CMV. We are also prophylaxing for Epstein-Barr virus. We are using valganciclovir. We are using Bactrim, trimethoprim sulfamethoxazide, prophylaxis as a standard. And then we are also prophylaxing against tuberculosis. We are using isoniazid in all our patients as TB prophylaxis. And that is pretty standard for us. We continue the valganciclovir for 6 months after the transplant, if we can, especially in the high-risk patients, the donor-negative recipient positive, the donor-positive recipient negative. Although for us in South Africa, most of our patients are positive. We continue the sulfamethox Bactrim combination. Although we have stopped it sometimes in patients who have side effects, but generally we continue that. And we continue the INH also long-term if we can. And that is pretty standard for us in HIV positive recipients, but it's also something we do in our high-risk, high immunological risk patients who get something like ATG on induction. I personally have not used HIV positive livers yet. I work in a very conservative and small liver transplant program. We haven't tried to expand our donors with HIV positive livers. partly because we don't have a huge demand for HIV positive recipients with liver failure. So I think if I had a high demand, I probably would have done that. But currently, I don't have a high waiting list of HIV positive patients with liver failure in South Africa, so I haven't used that. I can say that my colleague in Johannesburg has used HIV positive donor for a HIV negative recipient in a living donor transplant setting, where he had a child who was very unwell, and he elected to use the HIV positive mother to transplant the child with. But he also has not, as far as I know, done any HIV positive to positive, and he's just done that single case. The last question is in terms of rejection. So I think rejection is a very topical thing in HIV positive transplantation. It is probably the thing that drives a huge amount of the graft failure that we are seeing in this patient population. And it's interesting because we're thinking the patients are immune suppressed, but what they are actually is dysregulated in terms of their immune response to the transplant. And we are seeing high rejection rates even with ATG. I think in the South African context, what we're starting to see is that with ATG, the first year of transplant goes fairly smoothly, but then in year 2 and 3, we start seeing rejection again. So one of the things that prevent rejection is to have no interaction between your antiretroviral therapy and your immune suppression. And if you have access to the integrase inhibitors, I think that is helpful. I personally don't have access to those drugs. For us in South Africa, it's reserved for breakthrough HIV therapy, so I can't put my patients on that. But I think internationally it's been shown to have a good impact because of the fact that there's no pharmacokinetic interaction between the two different drug groups. The other thing I can say about rejection is that I think it's very important to manage these patients very carefully, to see them very regularly, to be quite aggressive in terms of doing a biopsy if the creatinine goes up, and to just be very proactive in terms of treating that.
Thank you very much. I don't see any questions in the chat box. And one last question, if you allow me to ask you.
I see Vasanti is putting her hand up.
Yeah, yes.
Yeah. Okay.
Can I ask a question? Yes, excellent talk, Dr. Elmi, and we are very happy that you will be taking over after Marcelo and giving a push to eliminating gender disparity in all walks of transplantation. It is commendable that you have converted disadvantage to an advantage, where HIV positive patients did not have an opportunity to be candidates for dialysis in your country, and by promoting HIV positive to positive transplants. I would like to know, you had mentioned that the female recipients for transplant in HIV positive was only 39%. Is it because of the low incidence of disease or the candidates on the waiting list, or is it that it is due to gender disparity? And number 3, what is the duration of ATT that you would give in HIV positive recipients if they had tuberculosis? Would you continue it for much longer, or what is the duration of anti-tubercular therapy? Thank you.
Those are great questions. So what I can say about having only 39% of my patients female is that in general, I find my waiting list is always male dominant. And it's probably something between who presents to dialysis, who gets access to the healthcare sector. I don't think it is because there's a lower incidence of HIV, but it is about a gender disparity in South Africa. If we look at the non-HIV group, we're seeing the same pattern. More male patients on dialysis, more male patients receiving transplantation. And as you said, something we want to address in our context in South Africa, but also internationally, and a very topical issue which we need to fix. In terms of ATG, we monitor the patients quite carefully, and if we see that their white cell count drops very dramatically and they become neutropenic very early, we would stop the ATG earlier. I have had patients where I continued the ATG for 5 days, 4 days, and some of them only 3 days. So that is why there is some dose variability in terms of my outcomes data. I don't deliberately decide that because the patient had previous TB, I would give less ATG. I usually try and have everybody screened and make sure they are free of TB at the time of transplantation. I do have to say that I have had 2 patients where we did actually find they had TB just after the transplant. I think it was reactivation TB. I don't think it was donor-derived. And of course, these patients are extremely difficult to manage, lots of drug interactions, and in that case, we stopped the ATG.
Samir?
Thank you very much.
Couple of questions. A very informative and excellent talk, Professor Muller. Just a point I want to ask is, do you have any protocol in your center about CD4 counts of the recipient before you find him eligible for the transplant?
We say 200. We want a CD4 count of 200. I have transplanted patients where the CD4 count's a little bit lower, as long as they are virally suppressed. For me, the most important thing is I want a virally suppressed patient. Some people struggle to get their CD4 up on dialysis, and I haven't been too strict about it. Our protocol says 200, but we're quite we're flexible about that.
And secondly, how low will you go on steroids in the maintenance dose, or would you prefer a steroid-free regimen?
I haven't used steroid-free. I haven't done that. I'm nervous of that just because of the high rejection rate. So we are keeping our patients on a low-dose steroid. We give them a combination, most of them, of mycophenolate and tacrolimus. And that's what everybody is on, more or less. But we keep them on prednisone, low dose, 5 milligrams long-term. To just prevent rejection, just because they're such a high-risk group.
Thank you.
Muller has provided gift of life to thousands of patients with HIV with her pioneering work in transplantation for the HIV positive. Thank you, madam.
Thank you very much, Dr. Muller.
Thank you. That is wonderful. Thank you for the opportunity to do this talk.
Congratulations for your wonderful work. I think your hospital has done the first cardiac transplant.
Yes, correct.
Your hospital has done the first heart transplantation.
Correct, yes.
Sure, yeah. I think this is the second landmark what you have done.
Thank you.
That's good.